Welcome to the Dusty Muffins, where menopause meets sisterhood and strength. We're three menopause specialists coming together to laugh, share, and empower you through the wild ride of menopause and perimenopause. Whether you're curious, confused, or just looking for real talk, you're in the right place. We're here to answer your burning questions, educate, and advocate, all with a dash of humour and a lot of heart. So pull up a chair and join the conversation. Before we dive in, please remember, while we're doctors, we're not your doctors. This podcast is for educational purposes only and is not a substitute for medical advice. We encourage you to partner with your own medical clinician to address your unique health needs. This is the Dusty Muffins.
I'm Dr. Rebbecca Hertel. I'm a board-certified osteopathic family medicine physician and a Menopause Society certified practitioner. I have a private telemedicine practice, and I see patients in several different states.
I am Dr. Aoife O'Sullivan, a board-certified family physician and Menopause Society certified practitioner, and I see patients through my telemedicine practice here in Oregon and Washington.
I'm Dr. Hart Kress, a board-certified women's health nurse practitioner and menopause certified practitioner, and I see patients via telemedicine in several states as well.
Welcome back to the Dusty Muffins. I'm Dr. Aoife O'Sullivan. Today we're diving into a topic we don't talk about enough in menopause care, the pharmacy perspective, supplements and holistic midlife strategies.
To help us unpack all of this, we're joined by Victoria Byrd, a licensed pharmacist, integrative women's health coach, and founder of Women Mastering Midlife, where she helps women understand the menopause transition and make confident, informed health decisions.
Victoria bridges clinical pharmacy expertise with integrative women's health, helping women make sense of medications, supplements, hormone therapy, lifestyle strategies, and the bigger picture of thriving in midlife.
Welcome to the Muffin Tin, Victoria.
I'm so excited. Thank you for having me.
Oh, it's such a pleasure. We've been so looking forward to having you on because you were such a gracious host to us on your podcast. Yes. So this is exciting to have you back on here.
It's weird to be on this end, though. Oh. I'm not going to lie.
I know. You're lacking that control that you have on your end, usually.
Yeah.
I know it's hard. Let's start a little bit with your story. Tell us what led you from working as a pharmacist to focusing specifically on helping women navigate midlife.
Yeah. So, I graduated pharmacy school in 2004. So I experienced if I think back, I experienced what happened with the WHI in the retail pharmacy setting. I saw the Prem Pro packs grow dust and all the things. And after staying home with my two children to raise them primarily for 15 years, I decided I have to get back into healthcare in some aspect. I felt like at the time pharmacy felt really a lot more like a Band-Aid than a solution. And so I started digging into integrative health. And that was around 2019. 2020, the pandemic hit and I turned 40 and I started having night sweats and hot flashes and waking up at 3:00 in the morning feeling like we're going to die and not understanding why. And I just never got good solutions from my doctor. So I started recognizing that I had to dig in and do my own work and do my own research and figure out how to navigate finding the right provider, taking care of myself, getting the solutions I needed. And I thought, if it's this hard for me with the background that I have, it has to be hard for everyone. So here I am.
And it is. That's what we hear all the time, right? From everybody.
Was there like a single thing that you took from that integrative learnings that you were able to apply to yourself when you were figuring all of this out?
Yeah. So the first thing, when I went to integrative, I did the Integrative Institute of Nutrition first because a pharmacist that I knew had done that program. And it really taught me about dietary theories. I started looking into the Mediterranean diet because it was so well studied and realizing that nutrition plays such a big role in how well we can live our life. So I started, unfortunately for my children, like we were done with the processed foods and we were done with the quick drive-throughs and buying glass instead of plastic containers. Like there was so many things I destroyed their childhood with by taking away all those fun things. But after that, when I started realizing I wanted to get into women's health specifically, I focused in through the institute, or it was the Integrative Women's Health Institute. And she really wanted us to understand the importance of nervous system regulation, that if you don't have your if you don't have your nervous system regulated, if you can't mitigate stress in some way, no matter what you do, you're just throwing the baby out with the bathwater. Like you're never going to have a clean slate to add hormone therapy or to look at supplements or your nutrition. So that was what really helped me recognize that it's not woo-woo to learn how to breathe, and it's not woo-woo to learn how to meditate. And I think a lot of women don't take the time to prioritize that.
Oh my gosh, yes. Another thing I think we all go through ourselves as well, right? Not just seeing our patients, but our sympathetic nervous system is upregulated so badly, especially the last few years with since COVID, really, I think, right?
And that's the second guest in a row who has offered that same advice. So for our listeners,
I was say that.
You can't be all wound up. You've got to find a way to prioritize yourself and unwind and let some of it go. Let it go.
Yeah.
And it's hard. It's really hard to do those things because, usually at this point in midlife, there's so many things going on. And then you add in, being business owners or entrepreneurs or, starting up or going back to school. And so all of the other life stressors that are occurring, whether it be the sandwich generation or, your own raising smaller children or teenage children or all of the above. And, I think we are just on sympathetic overload. I think, we're just think about like before we all hopped on here, I saw patients before and was trying to like finish up notes and grab some lunch. And, Aoife was doing some things before she was hopping on here. And we probably all should have I shouldn't say we all should have
started it
more because that doesn't sound very good, but we should have been doing some humming exercises maybe before we hopped on here. Remember, I did do a little bit of that not that long ago. I can't remember. I think I just was all wound up, and so I tried the just that gentle humming without being loud about it, and it did work. It did work a little bit.
What do you do with your clients?
So a lot of times I recognize that if I come into a conversation with them and I am frazzled, oh my gosh, I'm so sorry, I create an environment for them that they continue that perpetual frazzled feeling. So a lot of it is just sitting and taking a couple deep breaths, being a calm, soothing environment for them. There's visioning exercises that I've done before. And it's really funny because I think back to my very first retreat with the Women's Health Institute for health coaching. And we had to sit with our eyes closed. And we had this experience of, you're walking through the woods and you come to a house and what does the cottage feel like and look like? And an 85-year-old you opens the door, and what do you see, and what does she feel, and what does it smell like? And so it's giving you that opportunity to take a minute and think where do you see yourself, and what kind of experience do you have from that? And it was pretty amazing, the things that people came up with. But I remember having one eye open, this is crazy. Are we all really sitting here with our eyes closed? But once you get into adopting it, it really does make a difference in your calmness and your nervous system. I've also found that I have a couple playlists on Spotify of solfeggio frequencies, and I have them on in the background, and they really do help. Just a low it's a low hertz. There's specific hertz for anxiety and different kinds of feelings. And I just put the playlist on while I'm working or reading or doing dishes. Yeah. And that's actually pretty helpful too.
Oh, that's a great tip.
Might have to group chat that link.
I know. It is so fascinating. And, it's like we never want to just slow down and do those things that put us in that state of mindfulness, because I was at a massage yesterday and they're like, do you stretch? As he's finding all the things that's wrong with me. And I'm like, no. He goes, if you stretch, you'd feel better. And I'm like, yes, I know, but that means I have to be quiet and still. And it's such a hard place to be in 2026.
and take the time to do it, right? Because half the time we're rushing to get just a workout in because of all the other things. So you're like, okay, and then stretching. We tell everybody to stretch.
I
We
gotta get in
know.
the shower. I gotta go.
Right. Isn't that, although I will say sometimes stretching in the shower isn't a bad idea. I mean, be careful, but that is because, you're already, it's nice and warm. You're warmed up and then the water is warm. So you have less tendency to get hurt, but we digressed a little bit, but yeah.
Regulate your nervous system.
Yes. Yes. Well, and I say a million times, it's like probably a broken record at this point, but our generation was taught that if you aren't hustling, you're lazy. To rest is lazy. To nap is lazy.
Yep.
We were taught we could have it all. We could be it all. We could be we could be a CEO. We could be president of the United States. We could be the PTA mom, but nobody told us how. Nobody told us that, that it's okay to ask for help. That's something we were never told. Mm-hmm. And nobody told our counterparts that they're going to have to pick up some slack at home so that we could have those dreams. So we were being taught one message, they were being taught another, and all of it makes us burnt out, basically.
Yeah.
That's a great way of explaining it.
I love that. So Victoria, you often describe menopause as a pharmacological transition or a pharmacologic transition. What does that mean, and why is it so important for women to understand?
Want the Dusty Muffins at your next event? We do panels, live podcasts, and talks that bring the heat, literally. Corporate, CME, or retreats, we've got you. So hit us up at thedustymuffins333@gmail.com or DM us on Instagram at thedustymuffins.
So I think a pharmacologic transition in the terms of, we don't always need to be given an SSRI or a sleeping pill or, this, I'll add it up. We need to look at hormones. I'm not going to be a hormone pusher, but I want everyone to understand that it is a normal physiologic process for your body to stop making hormones that it used to make. And so when you're used to running on, I use the metaphor of a classic Cadillac car. You're not the brand new car that can take a beating and you can skip an oil change. You need to be loved a little bit tenderly. You need to put some things back, and you might need to add a quart of oil a little bit more regularly than you do with a new car. And you want to be a shiny, beautiful, cruising the highway on a Sunday car, and not the jalopy that's clankering into the gas station. And so it's a lot of really being gentle with yourself and understanding that there are things that are not your fault. There's physiologic processes that happen regardless of how well you take care of yourself. And we need to look at what we can do to supplement hormones in a way that aligns with them. Make sure they understand if they're choosing not to do hormone therapy, that it's for the right reasons and not for misinformed reasons. And while SSRIs and sleeping medications have their time and place, that shouldn't be the first thing we go to. We shouldn't silo every symptom into a different category of health, that it's a holistic one-person picture. And sometimes it's just an underlying cause.
Mm. And, what drives me mad is our societies here, like the Menopause Society, for instance, they constantly give the message that, no, we don't have any proof that hormones help with sleep. And then you look at those of us who see patients every day in clinic or have clients, and consistently we see how much hormone therapy helps with sleep, whether it be due to helping decrease anxiety or decreasing hot flashes and night sweats and allowing someone to sleep through the night, or not having to get up to pee 6 times a night. So it's so frustrating to be on that end of it and yet constantly get the message from the ivory tower that hormone therapy doesn't help. And there's a lot of people out there who can't take hormone therapy or don't want to, which is fine. But I think what you're saying is so true. We know it helps so much, doesn't it?
Mm-hmm. Yeah, I think there's the science of medicine and there's the art of medicine. And it's not, I just got done saying this to somebody the other day, that menopause practitioners are not putting people on medications in an unsafe manner. They're monitoring, they're adjusting, they're doing some lab work, they're running tests. I don't take estrogen without having my mammogram every year. My doctor won't refill my prescription if I'm not getting my mammogram. We have constant conversations about dose adjustments if I need it. But I think that when we look at, well, there has to be a standard, there has to be a guideline, there has to be this much research. We don't have all the metadata from 30, 50 years that people are trying to base guidelines on. And I just think it's unfair to ride the backs of the physicians who are in the trenches with the patients every day, doing what needs to be done to make their quality of life better.
We say that a lot too. Medicine is an art and a science. And my problem with this is that the artists or the clinicians, we use the science to help guide us in our clinical practice. We use our clinical experience to help guide us in our clinical practice. But the scientists refuse to acknowledge any of the art part of it. That's the frustrating part.
Mm-hmm. Yeah. And, by the time, I think the statistics are, by the time you're 40, you're on at least one medicine for some chronic condition. And by the time you're 60, women are on 4 to 5 because you keep adding. And would you say, from a pharmacist perspective, it seems like we're trying to sell to patients that your hypertensive, your lipid med, your bone med, your antidepressant, your sleep med have no risks associated with them, and they are better for you. That's how I feel like, the naysayers of hormones are presenting it, because we don't talk about all the dangers of all these other meds, right?
Yeah. And there's nutrient depletions that happen from medications. There's interactions that happen. There are times sometimes when I would work in the retail pharmacy, I would get a patient who I would say, I can't fill this right now. I need to make sure it's okay with your doctor. And it's, well, my doctor said it's fine. Just put the label on it. Like, what are you doing back there anyway? And it's like, well, but you're on 2 different blood pressure medications, or you're actually getting 2 ACE inhibitors, one from your cardiologist and one from a primary care physician. Like, you're going to have an issue with this. And I think that people aren't, there aren't conversations that are being had between care providers. Sometimes there are great physicians who have great relationships with each other. I don't want to make a blanket statement that's going to get the medical community mad at me, but I do recognize in patients, you give them this brown paper bag lunch sack full of medicines every month. And there has to be a better way. We're also not talking about their nutrition. We're not talking about their stress. We're not talking about their quality of sleep. I mean, I recognized even in myself, I wear an Oura ring. I've had one for 4 years. I wear it every night. I try not to get too hung up on the nights when I feel rested and I have a bad number. Like, I don't want to get in my head on that. But I've noticed when I would take trazodone, my quality of sleep was trash. My HRV was low. And so yes, you're giving me something to make me feel like I'm sleeping, but the quality of sleep isn't what I'm getting. On hormone therapy, if I don't drink alcohol that night, I have a great night's sleep. I have great quality. I have deep sleep. I have the appropriate amount of REM sleep. My HRV is getting higher the longer I'm on the right hormone doses. And so those are metrics that people aren't looking at to say, yes, we can lower your cholesterol. We can give you something to sleep, but is it actually making your body better? And I don't know if that's always the answer.
Yeah. And do you think as women go through the menopause transition and we lose our estrogen, that changes the way we can metabolize some of these medications even?
Well, I think that we're getting into gut health a lot more than when I was in pharmacy school. That's one of my lists of to-dos is to understand GLP-1s and understand the gut, because I'm not versed enough in that to feel confident to be an expert, have an expert conversation. But just knowing about the strobolome and the fact that if you're not taking care of your gut, you're not metabolizing your estrogen properly, and that you can have side effects from that. I think that's something we're now learning, is that we need to take better care of our digestive health. So I'm not necessarily, I think if estrogen receptors are all over your body, then you're going to have an issue with how drugs are binding to cells in your body. Yeah. I don't have the research that I could pull up and share data with you, but from an understanding of how the body works, that has to affect receptor binding. Absolutely. And so that would be something that we would have to get money to research, I'm sure.
Yeah, because really we haven't researched any of these medications in women, right? So there's just no way for us to really know this for sure.
No, why would you research a statin in a woman when you can research a statin in a man and just give a woman a male dose? Like, right. Why not? Right. It's so much cheaper that way.
Well, I have a question for you about when a prescription comes into the pharmacy. Can you talk to us about what actually happens before it reaches a patient?
Yes, I absolutely can. So it goes through so many different steps that I think kind of get ignored or just aren't understood. So when the prescription comes in, I'm used to paper prescriptions, but now everything is electronic these days. But so when a prescription is entered into the system, then somebody types it into what would become the label. And that process, then after that's typed, it goes to insurance and it runs through your insurance, and it'll either come back that it's, a $10 copay, a $30 copay, a $50 copay, or it requires prior authorization, meaning the insurance company doesn't want to pay for the drug that your doctor selected because they have a list of drugs that they want you to try first. And so if that's the case, if your pharmacist says this requires prior authorization, that means we have to call the doctor's office. The doctor then has to have their staff call the insurance company, give the diagnosis, give everything that you've tried and failed. And then the drug company or the insurance company can actually say, we're still not going to cover this. And then you have to choose to either pay out of pocket or find something different. A lot of times when it's prior authorization required, you're paying an even higher copay. So there's a lot of tiers of copays. It used to be you had a $5 copay. Remember those days? A $10 copay. And now it can be $150 a month for somebody to have a prescription.
Yeah.
But once it comes back from the insurance saying it's approved, then the pharmacist will review the prescription. So the pharmacist will look at all of the other medications that you're taking. Sometimes you go to different pharmacies, right? Like if you go to a doctor that has a pharmacy in the clinic with them, they might get that prescription filled there, but then they go to the corner store pharmacy to get all their other medications. And I don't have a way in my system to see what you get somewhere else until it goes through the insurance. So if you're paying cash or out of pocket for things, I may never know that there are medications that you're on if you're not going to tell me. But if something gets flagged, sometimes it's a big flag, like you're on 2 different blood pressure medications or 2 drugs that might interact with each other, or there's something that's contraindicated for a medical condition that you have. Those will be a hard halt for us. And we have to look at that and use our clinical judgment to say, you know what, this isn't really an actual interaction that's going to cause a problem in this patient. And you override it, which means I would put in my special code that says, I've reviewed this with my clinical knowledge and expertise. I say this is safe and effective, and I'm passing it off. So a lot of times if a pharmacist isn't familiar with the drug or the guidelines or what people are practicing, like with hormone therapy, if they get a contraindication like, oh, this patient is on Imitrex for migraines, they can't take hormone therapy, then the pharmacist will refuse to fill it unless they've heard from the doctor's office that it's okay. And so the issue of, it's not only a liability from a standpoint of I can be in trouble with my employer if I fill something that I've overridden manually, but it could also cause harm. And so that's where sometimes when people feel like there's a stopgap of like, my pharmacist should just fill it because my doctor knows better. Sometimes the doctor doesn't know that you're taking things from your endocrinologist and your cardiologist and your primary care physician, and these things don't talk well to each other once they're introduced in the body. So that's part of the issue before it even gets the pills get put in the bottle and the bag goes to the cashier.
I relied so much in, my experience in the military when the pharmacist was literally 10 feet down the hallway about, there's been some times that a pharmacist has saved my butt just because, they're the experts in the nuances of all the medications. And I've been super appreciative, but I think, now in this menopause space, I get frustrated because I'm like, you're the drug people. Why do you not understand that systemic estrogen and vaginal estrogen are absolutely fine? And I think, there becomes like, it creates some conflict. Has there been a push in the pharmacy community for more education around hormone therapy now that it's not collecting dust on the shelves?
No, it's so frustrating. Every year, I have to have 15 hours of continuing education credit to renew my license. And I've been licensed since 2004. So I have every 2 years I renew. So I have to submit 30 continuing education credits. And I go in and I search for my menopause continuing education, and there isn't any. There's nothing. I've just now started to recently see
boards either.
No, it's insane. And, so I went to the Menopause Society conference. I sat in the lectures. I submitted it to the board for continuing education, and it wasn't accepted because it wasn't ACPE approved. So I have 2 licenses. One of them said, if you want to attend a conference that doesn't give pharmacy credit, you have to ask us in advance if this is permissible. So I had 24 hours of continuing education that did not count for anything.
Wow.
So if you want pharmacists in the space to learn, you have to give us the education, and you have to let it count. I mean, it was $1,000 to go to the conference plus travel expenses. So it's not cheap to attend these things. And I got no credit toward my license. I still had to do continuing education on the current vaccines, or, I mean, those are all important topics. But if I want menopause to be my specialty, or even require a 1-hour continuing education across the states, every year when I go to fill out my renewal, I'm given a list of things I have to have done. I have to do a HIPAA training. I have to do some sort of law training. This year there was an equity training. I had to do HIV/AIDS training in Washington. I had to do death with dignity in Oregon. Like, there's all these things that are required of me to be licensed in a state. I've never seen a menopause or women's health education be required. And that could be a 1-hour read, an article and answer 5 questions, and there's nothing.
Yeah. It's disgraceful.
Well, Rebbecca, in case there's any pharmacy colleagues out there listening, or in case you would like some pharmacy approved, Rebbecca, Aoife, and I and our colleague, Dr. Heather Quayle, did 4 hours of menopause on the DOD. It's J7 Continuing Education Program Office. It is free, and it is the correct pharmacy approval. So you can, I want to say it's almost, it's got to be more than 4 hours. It's because I think it's more credits than 4. So there is that out there.
I can't.
Oh, that's good.
Our society is not credited for pharmacists. Like, I co-hosted a conference here, and we got our CME, and it came, was applicable to social workers and pharmacists and PTs, everybody. Like, it's so weird that it's not for the pharmacist.
I know. Well, and I wrote them. I wrote the Menopause Society and said, if you can get this approved, they will retroactively accept these 22 hours. And she's like, we didn't apply for that. I was really disappointed. So I don't know if I'm going to go next year. I might check out a different conference for women's health, because I just felt really
with us.
If it fit in my schedule, I was going to go this year, because it looks like it's a good time. But it was interesting for me to see what that society's education panels, what the symposiums were, and the talking points. And I don't know. I think I pay the membership because it's important for my clients to know that I'm part of the Menopause Society and getting those clinical pearls sent to my email box. But
did you leave a little bit confused?
I left thinking, where's the innovation?
Since found out, though, that one doctor who's very active in the menopause space did a reel recently saying that a drug company approached her to be a spokesperson for them, and they offered her 6 figures. But one thing that she had to agree to for 1 year was to not talk about hormone therapy. Now, that Menopause Society was covered, that hotel, from head to toe in Bayer signs. Every elevator, every pole was covered in a fabric Bayer advertisement. So you can imagine, if a drug company is pouring that much money into a conference, that there's a chance some of the lectures could be biased, and that was definitely the feeling I got that last year. Can I tell you something about pharmacists in Ireland, Victoria?
Yes.
Let's ask you a question here. So there's something in Ireland called the Common Conditions Service. So it allows trained pharmacists to provide treatment for minor ailments without a visit to a doctor. So these are what you can do: allergic rhinitis, cold sores, conjunctivitis or pink eye, impetigo, oral thrush, shingles, uncomplicated urinary tract infections, and vulvovaginal thrush. So I think that's brilliant. Do you? Do you think pharmacists should have a little bit more training, possibly in things like that, and then have a little bit more leeway helping patients? Because you can go to your local pharmacy in Ireland and talk to the pharmacist and say, these are the symptoms I'm having. And the pharmacist can say, well, let's try this. And if it doesn't work, then make sure you see your GP in 4 days, you know.
Feeling off in midlife? I'm Dr. Rebbecca Hertel, and I offer concierge telemedicine across multiple states focused on hormones, weight, libido, and sleep, and longevity. Let's get you thriving. So visit www.osteopathicmidlifehealth.com.
Yeah, well, absolutely. And it's the issue that we have in the United States is that pharmacy is regulated state to state. And so in the state of Washington, I have provider status. So I can be educated on dispensing birth control out of a pharmacy without them having to go to the doctor. We can do tests to treat. There are certain tests we can give and certain antibiotics. There are trainings that are involved. And you can also have collaborative practice agreements with doctors' offices. That is, yeah. So I could work with a doctor and prescribe hormones myself, given the parameters of a collaborative practice agreement.
Wow.
Yes, there's also client service agreements where you can offer chronic care management, medication therapy management, or what's called remote physiologic management. So a pharmacist could take a look at your glucose monitoring or your blood pressure monitoring and be able to work with the doctor and kind of be that bridge between visits of saying like, hey, you're not checking your blood sugar, or you're not filling your metformin very frequently. Let's talk about why, how is it making you feel? What are you doing with your diet? So those are things that pharmacists are able to do, but that's really state to state dependent.
So we're really not, pharmacists are not being not able to use their license to the max, really.
Yes, in some states.
Yeah.
Mm-hmm. And I think that it's interesting in pharmacy. I feel like, I don't know if it's the kind of person that goes into pharmacy, but we're very risk averse. So I wonder if there's a lot of people who don't understand that they could practice to the top of their license that aren't. That being said, there are also pharmacists that I see that are doing agreements with peptide companies. And I wonder, like, is that pushing into prescribing or working outside of the scope of practice of pharmacy in your state? So that's where there's still some hesitancy of what can I do and not have my license revoked, because you work really hard for that. So, but yeah, I think after COVID, especially, there were a lot of states that said, let's give not just vaccinations. Because when I went to school, we didn't touch people. We had nothing. We were behind the counter. And then right before I left retail, we started vaccinating, and it was a new experience. But even then, the pharmacies aren't set up. I took my daughter to a CVS that's inside a Target, and the pharmacist walks out with his caddy, and he had the vaccine in his mouth. He had the syringe in his mouth, walks out, puts the caddy down on the bench outside of the bathroom with his paper stanchion thing. And I'm thinking, how do we think this is okay as a way to give people vaccines? I mean, yes, it's a flu shot, but so I don't think that the pharmacies are set up in a lot of places to provide the care that they could. And when you're dealing with a retail pharmacy, there's metrics you have to meet. I remember I worked for a chain that we had this half circle gauge, and you'd start out in the morning and you'd be green because everything was caught up. And as prescriptions weren't meeting their time stamp of when they should be checked as ready, you would go into yellow and you would go into red. And they would monitor how long you spend in a day in the red zone. And so anytime you have to call a doctor's office, anytime you get out onto the floor to give an over-the-counter recommendation, if you had a patient question, anything would set your metrics off, because if the computer would determine it should take you 15 minutes to get this prescription from start to finish. And that 15 minutes, I'm supposed to have it typed in. I'm supposed to check the accuracy of the prescription to the hard copy, check the medication in the bottle, make sure there's no interactions, also answer phone calls and do vaccines, and go to the drive-through and answer a question at the drive-through. So you're expecting this on retail pharmacists. We would love to be able to go over your continuous glucose monitor results and be able to offer birth control to people who don't have access to care, especially in rural settings. There's a lot of things that we could do to help the healthcare system, but I don't think we're set up in a way. Yeah. Yeah. And pharmacists, independent pharmacies just aren't making money right now. You've got PBMs that are controlling reimbursement rates, and pharmacists are barely scraping, making ends meet in an independent pharmacy. And that's where you would really see the access to those kind of programs.
Can you take a minute to talk about our two things, our patch shortages, and then briefly going over like compounded medications, FDA approved, not FDA approved? Because I think a lot of people get confused with that. So what's going on with our patch shortages, right?
Oh, for Pete's sake. Yes, I know. I'm part of it. I experience it myself.
And then compounded hormones versus, the FDA approved options that they get through their pharmacy.
Yeah. So the estrogen patch shortage is it's an interesting thing because I looked at the FDA website. I regularly check it. There's never been an estradiol patch shortage on the FDA shortage list. So the federal government isn't saying there's a problem with our patches, but I can't get a patch to save my life. So one of the issues that you see is it's manufactured based on demand, and drug companies are obviously going to want to make medications that give them more money back. There's not a lot of money in hormone patches, honestly. But also for a long time, there wasn't really the demand that there is now. So some people are saying it's not a demand problem, but there is some supply demand issues because now with the FDA removing the black box, I'm thinking it might just be my algorithm, but I feel like every time I turn on social media, somebody's talking about hormone therapy. And I think there's a push to start it in perimenopause versus just menopause. So there's a lot more education around getting a patch and getting it early. So you have a lot more people desiring one. But you also have drugs. So there's the drug manufacturer and then there's distributors. So sometimes a big chain has their own warehouses of drugs. But then they also have specialty. When I worked, it was McKesson and Cardinal were the two distributors that you could order from. So you get a weekly order from your major distributor of things that you use that you need to replenish. But then you can also order overnight whatever you don't have in stock when a prescription comes in. So Cardinal or McKesson would be where I would put it in. I'd put in the request. And then the next day around noon, we'd get totes. We'd open them up. And that's when we would see if we got something or not. It was like a surprise bag. You never know if you're going to get it. And so if those distributors get to decide where they're putting those patches, like if they have 50 boxes in their warehouse and this pharmacy needs 20 and this pharmacy needs 10, and maybe there's contracts that I don't understand how those are negotiated for distributors, they're going to partition out the medications to their pharmacies how they see fit. So even if it's not the pharmacist's fault, they're putting in that order every single day. I'm putting in an order to request these drugs, and they will auto substitute. If you specifically want the Sandoz brand of the patch, because that's what your patient wants, you put it in, they will auto sub. There's nothing you can do about it. And so then the question is, do you want to wait and play roulette and see if we're going to get the other manufacturer tomorrow? Or do you want to take the manufacturer that you may not feel works as well for you, or you don't like the size or the adhesive? So that's an issue. And so that's part of the problem that we're seeing. I wonder if there's been some delay in removing the black box off of the packaging, that's also causing a delay because now all of a sudden they can't make a box with that. And so maybe there's a little hiccup with that. But the UK or Australia, and is it the UK, that they've had these shortage issues for a long time and they saw this coming for a very long time. So it's not like it's a new thing. But I don't think anybody really wants to tell us why they're not pumping out patches as fast as they should. But it's at the end of the day, it's a money thing, in my opinion. But that's the process of how they get to your pharmacy. And then for compounding pharmacies, I know I was never a good compounder. In compounding lab, I never did well. So I knew it was never going to be for me. But in a compounding pharmacy, they'll get a prescription for testosterone cream is what I get compounded. And that is made, they'll take your active ingredients, your inactive ingredients, like fillers, if it's going to be a capsule, or the base that they need to put it in. There's a lot of chemistry involved, which is never been my strong suit. So they need to make sure that the pH is correct. They need to make sure that the drug is going to be absorbed into the cream the proper way so it doesn't get gritty, because texture is an issue. The drug needs to be distributed between the cream perfectly in order for you to have a dose that's the same every time. And there's no standard for each time one is made, right? It's very hard to test the strength or the concentration of a drug in something that's compounded. I know that from even just working in an IV room in a hospital, you're taking a clear liquid and you're injecting it into a clear liquid, and then you're supposed to draw back the syringe to where you, like if it was 5 cc's of a liquid that you're adding in, you would draw back the syringe to a 5 and put the empty syringe into the tub. And the pharmacist would have to say, this clear liquid looks like it's made correctly. It's mildly terrifying in my opinion. But that's how things are compounded. So if a technician or somebody in the pharmacy, the compounding pharmacy, is making this, they're weighing out a powder of testosterone, and then they're putting it on a slab with the cream, and they're mixing it until they feel the consistency is correct. So there's really no way to gauge if it's the same dose as it was last month, if you're getting the same dose every time you pull out a pump. And so it makes me nervous. And I'm somebody who, bless you, I'm somebody who got my own prescription compounded last month. But my provider doesn't feel comfortable dosing male estrogen for me. I asked specifically, I said, I really don't know if I like this whole compounded thing. Like, it's a cream in a tube and I don't know who made it. And I don't know if it's the strength that it says it is. And she's like, I just don't feel comfortable dosing male testosterone. So
there's international guidelines on how to do it.
Thank you.
There is.
Like typed up online, freely available.
So I have to bring that into my doctor's office. Okay. Maybe we need to, we'll find that. Can we put that in the show notes?
International guidelines, not just Washington State, like international guidelines.
Yeah.
A thing. Yes.
Yeah. But I had to,
it's getting hard to defend this ridiculousness. Sorry, Christine.
Oh, I was just saying on that compounded, I had a patient who's been on compounding for a long time, testosterone cream. And I saw her this week and she's like, and she's even on a lower dose, so 4 milligram compounded testosterone. She's like, I was feeling great until November when I picked up this new prescription. And the only thing that changed was the bottle. And she was sitting about 60 on her testosterone, and now she's up to 300 and something. And there was nothing that we did differently, not the dose, not how she applies, where she applies. And so that's the challenge and the sort of risk with the compounded.
Sure.
Yeah.
Although I will tell you, some of that runs true even with our patches, right? Like certain manufacturer patches. And I've experienced it myself where I've gotten a different manufacturer and I've flashed through it, or it's not the same as the one before, right? The manufacturer before. And so, I think we can experience that with generic forms of other types of medication.
Well, I think that's more like how that adhesive bonds to our skin and, because it's to do with the adhesive, right? But definitely with the compounding, I love my local compounding pharmacy. I use them a lot. But I have called them a couple of times to say my patient's testosterone was 450.
Like, did you do anything different?
Yeah. Yeah. Well, and I don't know if the pharmacist compounds this day and this technician compounds this day, or, it's an exact science. I would go into compounding lab to make a suspension and come back the next day and it was a rock solid, like it was solid. I got a 0 on it because my liquid didn't stay liquid. So there's such precision required for a lot of these things. And, we talk about the therapeutic window of a drug. And so when a drug is manufactured, it has to stay within a certain plus or minus in a therapeutic window. So it doesn't have to be exactly this precise dose every single time. And so with hormones, when I would give somebody a thyroid, like levothyroxine, if they got put on a manufacturer of that thyroid medication, they would do fine, even if it's a generic versus brand, as long as they stayed on the same generic. When you start moving into different generic brands, that therapeutic window can make such a big difference with hormones. So I think that might also be what you're seeing when you switch from Dottie to Sandoz to Mylan. You're seeing those shifts in the therapeutic window that are allowable by the FDA, but really make a difference when you're talking hormones.
I always counsel my patients about that because I'm like, just write it down. We used to be able to ask for our Mylan patch or whatever, but now I'm like, just take what they'll give you right now.
I know, it's better than nothing.
So, Victoria, I'm sure being a pharmacist, this topic may drive you as, a little bit bonkers as it does me because, everybody's got a TikTok recommendation. There's not a visit that I don't see a patient where they said, I saw I should take this supplement on TikTok. What are your top 3 supplements that you can cope with, and are there any red flags that you see in the midlife supplement industry?
So I think first of all, try to get it from your diet. You're going to get a better result if you're having proper nutrition. You can get magnesium from dark chocolate, but magnesium is definitely something that I would say is one of my top supplements. A vitamin D supplement, I think, is another one that I've pretty much said magnesium glycinate and vitamin D are the 2 supplements that I would absolutely say, obviously make sure with your doctor first. And if you have a vitamin D blood draw, it's an important baseline for a lot of people. Out here in the Pacific Northwest, I feel like it should just be in our water. We should just have vitamin D for everyone. And then things like creatine, there's really great studies on it. It's very safe. They're talking about it with cognitive health and with muscle health. It's not going to make you become a gym bro. It's a very safe and effective. You're not going to become the She-Hulk if you take creatine. And then there's things,
Victoria,
like supplements. Right. Thanks. I mean, the amount of work it takes to become that bulky is far more than we all have time to do. So you're going to be fine if you take creatine and you lift some weights. But I think, there's talks of things like berberine and ashwagandha and the herbal supplements. I am really particular about whether or not I would recommend those. I think nutrients that you're missing from your diet or nutrients that are depleted because you're on medications that can affect nutrient absorption from food, those are things that are good to put back in. I talked to Dr. Matsumura about melatonin, and I'm a fan of melatonin because if our bodies, it's a hormone we're not producing at the same rate we did when we were younger, then if they're having sleep issues, that's definitely something to consider. But it's really individualized. I've had people come to me and say, could you make a midlife supplement protocol? And I just don't work that way. Everything is so nuanced and every person is so different, and what they're taking and what could interact with other things. I mean, I saw when I was in pharmacy, the St. John's wort craze, and then the St. John's wort babies that came after it because it interacts with birth control. I've had women also look at the teas you're drinking. Like there's all these herbal teas and supplement teas and beverages that people are drinking that have things in them that, I worked with a woman who was taking, she was taking birth control pills and was having issues with it when she hadn't for years. And I said, well, what else are you taking? And then I said, are you drinking any teas or supplement beverages? And she was taking this estrogen interacting supplement in her tea that she had never even thought about. She thought it was good for midlife women. And so I think really having the opportunity to sit down with somebody to consult through what you're taking, how you're eating, and what could be added into to supplement is much better than creating a standard midlife protocol.
We really have about 8,000 more questions for you, but we have to let you go at some point. So before we let's finish up, we'd love to know a little bit more. You've got some beautiful websites and you're a coach. And you have a course that you do with women. Can you tell us a little bit about how you help our patients?
Absolutely. So I created Women Mastering Midlife podcast community as a space for women to be able to come together and talk in a safe space about what's going on in life. So we talk about not just nutrition, hot flashes and night sweats, but also that you're in a career that's burning you out. You're having relationship issues. You're taking care of your parents, all the things. One of the things that's most selfish about having a podcast is you get to meet really cool people that you get to have conversations with.
Yes.
And so then, right. So then I take those and we break them down in the community. So I really love that that I have that. And then in working with women, one of the things that is hard as a pharmacist is I don't have prescribing power, but what I do have is the ability to sit and talk about all the things for a very long time. So I prefer to work 4 to 6 months with a woman because we've gotten in our minds that immediate quick fix is the answer, or the 4-week weight loss program or the 6-week diet is going to fix everything. And it really takes a lot longer to establish habits that are going to stick. And it may not necessarily be as complicated as you might think it is. Sometimes it's just let's look at your sleep routine, and let's look at your breathing, and let's look at, your community. Do you feel fulfilled in your career? Do you feel fulfilled in your relationships? It's so much more complex than just give me a prescription at the counter. And that's what I like to do. I have the background so that we can discuss supplements, we can discuss your prescriptions, and I can make suggestions that we could take to your doctor and help you have those conversations with your physician who may not be as versed in menopause and midlife women's care. So that's what I like to fit in. I like to be the bridge.
That's wonderful.
Thank you.
You're such an amazing source of information and such an amazing source of support for women. So tell us how
Thank you.
Can find you, Victoria.
Well, I made it very simple. You can find me at womenmasteringmidlife.com. Everything is there.
And the podcast as well. There'll be
It's all there. Yeah.
Episodes.
I'm recording my 100th episode this week. So
Congratulations.
Yeah.
That's
amazing.
Yeah, it's great. I feel like it's a way for people to get all sorts of information on their time. And like I said, I selfishly get to meet people because if I say, you want to come on my podcast, that's a great way to get to meet somebody.
It is. Yes. It is. I know. Christine's actually better than.
She's the best.
She really is.
Yeah.
All right.
Thank you so much for joining us today, Victoria. It's been such an enlightening conversation.
Thanks for having me.
Yeah, and if you'd like to learn more about Victoria and her work, please visit her at womenmasteringmidlife.com and check the links in our show notes for her resources and guides.
And if you enjoyed this episode, please like, follow, and share the Dusty Muffins podcast so more women can find these conversations.
And remember, while we're all clinicians, we're not your clinicians. Use what you learned today to start a conversation with your own healthcare clinician.
All right. Thank you. Have a good one.
Everybody.